Dr. Moseman, can you hear me?
I can. Can you hear me okay?
Wonderful. Yes, we can indeed. So you have got a PowerPoint that you're going to share. Is that correct?
Yep, that's correct.
Perfect. Okay. So do you have the Zoom client opened on your browser?
Yeah, it's in the bottom left-hand corner. Is that right?
Yeah, just on the bottom. Oh, it looks like you're figuring it out right now. Perfect.
Great. Is that working?
That is working. So just before you take off here, I'm going to introduce you to everyone. I'll read your bio and then I will let you take it over. How does that sound?
Great. Perfect.
All right, wonderful. So if you're staying with us, we've got our next session here. And if you are just joining us, welcome to the Eating Disorder Hope Virtual Conference. We've got our second session about to begin, and this is our second CE session as well. So there is a CEU, a continuing education credit offered for this session. In order to qualify for that, you need to be present for the entire hour, as well as complete the Google form that I will insert the link to in the chat feature after Dr. Moseman's presentation is over. You'll need to complete that and submit it in order to qualify for that CEU. But before I let Dr. Moseman begin his presentation, I would like to read his bio so you know a little bit about him. Dr. Moseman is the Medical Director of Laureate Eating Disorders Program. He has worked there since completing his child psychiatry training in 2004. He is a board-certified child and adolescent psychiatrist who received his fellowship training at Western Psychiatric Institute and Clinic in Pittsburgh, Pennsylvania, where he served as chief fellow. He received his medical training from Texas A&M Health Science Center and completed his adult psychiatric training at the University of Arizona. Dr. Moseman has spoken internationally on topics related to child psychiatry and eating disorders. Currently, he's collaborating with Sahib Khalsa, MD, PhD at the Laureate Institute for Brain Research to study neural circuits associated with eating disorders, nutrition, and body image using the facility's state-of-the-art fMRI and float clinic. Dr. Moseman is a strong advocate for families of eating disorders patients and has served on the board for the Oklahoma Eating Disorders Association, the American Academy of Child and Adolescent Psychiatry, and as co-chairman of the Academy for Eating Disorders Special Interest Group on Child and Adolescent Eating Disorders. He also maintains an outpatient practice with specific areas of interest, obviously including eating, mood, and anxiety disorders. So that's a little bit about Dr. Moseman. Throughout his presentation, of course, I'm going to be here in the background. So if you have any questions that you would like to ask or any concerns at any time, just let me know in the chat feature and I will hopefully try to solve any and all problems for you. So without further ado, here is Dr. Moseman. Welcome, Dr. Moseman.
Great. Thank you, Kirsten. I will apologize. You don't get to see my lovely face today. I work for a Catholic non-for-profit hospital, and they are highly regulative of our IT, but hopefully you can hear me and happy to answer any questions and go through some neurobiology stuff with you. So as Kirsten has explained, I am the medical director here at Laureate. I've been here for almost 15 years now, and I really enjoy and get the ability to work with patients, both inpatient and outpatient. I'm FBT trained. I do and run a residential program. I do research. So I kind of have experience with eating disorders from all angles. I'm happy to present to you a presentation I do a lot for families, professionals, to give sort of a basics of how we look at the illness, how we look at neurobiology, and hopefully give you some insight about how I use it to better treat patients, whether it's on an inpatient or outpatient basis. So to get started, we're going to talk a little bit. I'm going to be brief since I know most of you are professionals, a lot of you that treat eating disorders on a pretty regular basis, but I'm going to be talking about sort of the history a little bit of how do we get to actually call it eating disorder an eating disorder, talk a little bit about the main eating disorders that we tend to treat as clinicians, and go through classifications briefly since I know that you guys know that already. But that will sort of lean us into this idea called research domain criteria. This is a criteria which really looks at when we're defining illness and when we're looking at better treating illness, how do we look at specifically neurobiology? How do we look at brain chemistry? How do we look at the CNS and figure out how we use it when we're using meds or we're using therapy or we're using any other type of intervention? We'll talk about specifically about eating disorders, especially this idea you'll hear me talk about again and again, which is the idea of state and trait criteria. Unlike some other medical illnesses, certainly unlike some other psychiatric illnesses, eating disorders has something that happens when you're not eating correctly and how it affects your brain and your thinking and how the disease expresses itself, as well as there's some baseline underlying genetic neuropathology, which places one at risk and continues to be traits and issues that people with eating disorders struggle with, even when they're in the recovery and weight restored portion or lack of symptom portion of their recovery. And then, most importantly, a little bit, I'm going to talk about a couple of studies that we've done and talk about how I look at it, both inpatient, outpatient, how I'm using some of this information of how the brain works to actually treat patients. So, the first idea is, why consider neurobiology? In looking at diagnostics and looking at, is something an eating disorder? When do you have dieting? When do you have eating problems? When do you have, normal self-esteem or body image issues that can happen now in males and females on a normal basis? How do you sort of cross over that threshold? And I think as we're looking at how these diagnoses are made, as we're looking at the difference between diagnosis, I think some movement in the field towards neurological underpinnings is going to be important. And to give a factor, to give sort of a feedback in looking at how the brain is working and changing to see if you're doing an intervention, is it working? When do you know that somebody's well? When do you know if somebody's having a relapse? Lots of times we're relying on report or weights or other kinds of things, and understanding actually how someone's thinking or how their brain's actually working certainly could be helpful. Being a child psychiatrist, and as sure as most therapists and other people that work out there, there's always this idea of the biopsychosocial summary that you do to look at a patient. And I really feel, certainly as a psychiatrist, certainly as the one that's sometimes prescribing medications or working with that, feel like that biological component of the brain and the body and how they interact and how they work is sometimes probably the most overlooked. In the field for so long, we put huge emphasis on psychology and huge emphasis, especially on family systems. Not that they're not important. I mean, you can look at FBT now as using a family system for good, but for a long time we blamed families in the field. We caused some issues around looking too much at interactions and not as much at the person's programming, the person, how they're wired and how that works. And then certainly we look a lot at social, especially if you're dealing with patients in being a child psychiatrist or adolescent psychiatrist in the 13 to 18-year-old range. There's certainly a lot of social stuff going on there. That's a very important part of their development, as well as looking at other social things. So I think this biological mechanism is the one that probably gets the short end of the stick. As I said, I have trained and do FBT in my outpatient practice. I'm maybe an uncommon believer nowadays in that I'm not a one-size-fits-all of anything, whether it's inpatient or FBT or using dietary care or what types of therapy to do. I'm really, again, as I look at things through how the brain works, it's more, how do I take an individual? How do I take a family system? How do I take, that brain and those traits, and how do I get somebody eating properly, get somebody less anxious, get somebody well over the period of time? And finally, I think certainly neurobiology will lead to, better and more individualized interventions. In general medicine nowadays, you're certainly seeing a lot of, bioidentical hormone, treatment. You're, looking at the fact that individually we're different genetically, and so sometimes a one-size-fits-all model, medical model, doesn't necessarily work for everybody. And so understanding not only neurobiology for things like anorexia nervosa, but neurobiology of an individual probably could be very helpful in using interventions that we want to work and make our patients feel better and stay better. So again, very briefly, in psychiatry right now, we're on the DSM-5, the Diagnostic and Statistical Manual version number 5. All the DSM started back after World War II. It was sort of first a US thing. It became an international thing, certainly since the 80s. And, with ICD codes and insurance and, the fact that eating disorders certainly became part of the vernacular and part of DSM, there's this idea of defining them currently. If you say somebody has anorexia nervosa, you're meeting DSM criteria. You can go through most of your professionals and know the criteria. Certainly they have changed over the years. Certainly the ideas of how body image fits versus how just denial of seriousness fits, the idea of whether menstrual periods are necessary or not. And certainly I think most importantly, the idea of the healthy at any size phenomenon, the idea that just like genetically, not everybody with anorexia has the same sort of underlying neurobiology. Everybody gets the illness does not necessarily have the same underlying genetic weight philosophy as well. I mean, not philosophy, but underlying genetic weight. Everybody at the same height shouldn't weigh the same. Using things like just 85% or trying to come up with something sometimes misses out on the bigger picture of health and how the brain's working and how anxiety and depression, other kinds of things filter in. Certainly in DSM-5, the severity criteria came in, and those have been somewhat controversial, as again, talking about expanding out to behaviors and individuals and then going back to BMI, which is a very population-based number. Bulimia, as well, again, the idea of now it being once a week, the importance of the idea of non-purging types, of this idea of chasing sort of dopamine or chasing the need to feel better right away, and then certainly things that we'll discuss as underlying the same. Severity criteria certainly based on episodes per week. Certainly new for DSM-5 is binge eating disorder. Certainly if not a new disorder at all, it's certainly the most common eating disorder. It's one that I think the treatment community is trying to find what's the right place to treat it. Certainly so much of our care is set up by payment methods and who's paying and how that's working. And so trying to find a way to treat this very serious eating disorder and getting proper control over it. Me as a researcher certainly seeing that it's sort of like, bulimia without the undoing, but what creates that difference? Why is that difference? Why do some people choose to undo? Why do some people not? As well as seeing that there's differences in the sex distribution between these illnesses and how does that make a difference as far as hormones are concerned and how the brain works, I think is very important as we look forward with research. And then other or feeding eating disorder, not elsewhere classified. And again, so I think when you have a system which is based on collections of symptoms that you put in certain boxes and you have to meet so many criteria to make a criteria or not, you just get left with somebody who certainly has significant eating symptoms, something like purging disorder, where they're not binging and purging. Maybe their weight's not off, but they're purging nearly everything they eat. Certainly would be serious, so certainly something need to be addressed. And so I think it's important to look at these as useful in what we have, but in trying to look at the individual, how their brain's working, why and how they're using their symptoms, I think is going to be very helpful over time. So, if the idea of the fact that right now we use this DSM to make diagnosis. So if you're a provider, if you're a dietitian, if you're a therapist, if somebody is presumed to have an eating disorder, they come in your office, the job that you're trying to do is saying, does this person have an eating disorder? Some people that are low weight, sometimes even relatively low weight, don't have eating disorders. There can be other explanations for how their weight gets low and how things work in that regard, and that may make for different treatment. So the idea of research domain criteria has been around for probably about the last 8 to 9 years in the psychiatric field. And it really probably is the future of diagnosis and treatment, both from I think it's the only way to move forward, as well as from the standpoint that actually the National Institute of Mental Health, when it was under Tom Insel, actually decided that, like Dr. Khalsa, who I work with, or Dr. Feinstein, these people that are getting their major grants, their K award developmental grants, their R01s, which fund their funding in their labs, most of that money, unless you're getting it from the industry, is coming from the federal government. And so looking at the fact that nowadays, if you do not have something in your grant that represents mental illnesses as brain disorders with pathology affecting brain circuits, and specifically talking about brain circuits, you're basically not going to get your money. You can't get your money. You can't pay your bills. You can't pay your research assistants. So that the field is actually putting through, through the research way of trying to figure out through this mechanism about how these illnesses are treated, about how either treatments or things work. And so the hope is science takes some time over the next 20 to 30 years, how well we understand the brain, how well computers can actually look and synthesize data, and more AI or artificial intelligence where they can actually set up models that look more similar to the brain is probably going to take things very far in the future. So, but the idea of research domain criteria is that you have a brain which is made up of different circuits. And the idea is these circuits can control things like how you respond to reward, how impulsive you are, how strong your emotions are, and how you express them. And those sort of correspond to different brain regions, which might impact those. And I won't go into too much depth, but there's, obviously those things would be different. And then, you would target certain treatments to see certain changes over time. Now, the problem in looking at the brain is it's a complex organ. It's hard to get to. People don't like you messing around with it. Taking samples or doing things or rooting around in there, it tends not to be very well received. So, trying to figure out how it works is more difficult. So one thing you can look at is an electrical organ, right? So you can do EEG if anybody's had a sleep study or have a loved one with epilepsy or seizures. You can understand that electrical pulses is what releases certain chemicals to have the brain work, and not only the brain, but the other neurons in the nervous system that runs throughout our body. The other is genetics, right? So understanding the genetics of reward, anxiety, set shifting, emotional expression, those kinds of things can be important. Functional neuroimaging, so instead of just taking pictures of the brain and what it looks like, now just the size of things can make a difference. If an illness tends to have something like, if you have sociopathy and you're a serial killer and you have a very small amygdala, that's been proven again and again to everybody who's been examined. But the idea of functional neuroimaging actually looks at the fact that you take a look at the brain either through PET scanning, which actually looks at little radioisotopes, that looks at chemicals. It in fact looks at receptors in the brain and tries to see, for example, in bulimia, when there seems to be a higher proportion and a change in dopamine receptors in a part of the brain that's around reward and those kinds of things than controls, and certainly much greater than those that experience restricting anorexia, you can start to sort of make some inferences about how that person perceives reward and how that makes them more likely to either binge or purge or undo. What we do here at the Brain Institute is the functional MRI. So an MRI is a way to look at tissue, which is sort of in very sort of high definition as compared to CT or X-rays or other kinds of things. And the functional part stands for the fact that, and these are done with big magnets, which is nice because there's no radiation, no risk of cancer. But these big magnets can look at tissues, but they can also look and see where blood cells are dropping off oxygen. Anybody that's had to survive through biochemistry or physiology knows that oxygen, you've got the Krebs cycle, it puts out ATP, all our cells do that. And so the inferences you make is trying to see, when you have somebody doing something in the scanner, where is that oxygen being dropped off? Is it being dropped off at a part of the brain that controls this or that? And then trying to see if it is done differently when somebody has the illness or not. An example might be if you have people with very avoidant restricting anorexia in a scanner, and you give them a card game where they're going to win a bunch of money, and unfortunately for them, the card game is rigged. Now it's rigged in a positive way usually, that they always are going to win something. You can see them versus controls versus bulimics. Like the way that they deal with reward, or more importantly, the way they deal with punishment, is different. And so you actually have them do something, you see how their brain responds, and then see how somebody with an illness, their brain responds differently than somebody that does not have that illness. There's also, since we're looking at the brain, there's a bunch of neural proteins, and proteins really determine what cells do and how our body works. And so there's a set of about 50 or 60 of them that you can actually get from peripheral blood, so you don't have to get central nervous system fluid, where you can look at the fingerprint of these neuropeptides and see. There's actually a test for schizophrenia that will actually show positives even before the person has their first psychotic break. And so, again, these are all sort of like biosignatures. As a child psychiatrist doing this for the last 20 years or so, I don't get a lot of biological information. I'll see if somebody has anorexia, how their body is, and if they're malnourished. But the amount of feedback I'm getting about how their brain works and which medicines might work is pretty minimal. And even genetic information I'm usually getting, there are some genetic tests now. Most of those are around how drugs are actually metabolized and not how well drugs will actually work. And if I get biological genetic information, it's usually asking about relatives. If you have an aunt and a grandma and everybody has anxiety and everybody's done great on Prozac, well, there's a greater chance that the patient might themselves as well. So examples is being a physician. If you look at diabetes, you look at syphilis, you look at lupus, on different sides, there's some illnesses which might just present as like diabetes does, as you have a very high or very low blood sugar, but you don't always use the same intervention to treat that, right? Some people might have it because their peripheral system is not taking up the glucose. Some might have it because their pancreas is just not working, and so those would have different ways you treat it. Something like syphilis or lupus might be different in that in those illnesses, you actually have illnesses where the same thing's causing it, but it might affect your joints or your brain or something else that's different. So an example of this is there was a study in JAMA Psychiatry, and you can certainly look at the slide, but I'll kind of get it down to something more specific. There's an area of the brain called the anterior insula. It's a very important part of the brain that we study a lot in depression, anxiety, and in eating disorders. And I truly believe that eating disorders are stress and anxiety disorders. So the anterior insula, when you looked at it, and they had trials of both doing Lexapro, which is escitalopram, or cognitive behavioral therapy, and they looked at people fully getting better and not just having a response. Well, what they saw is they would look at how busy that area of the brain was compared to the rest of the brain. And when it was sort of less busy than the rest of the brain at rest, then those people tended to do better with cognitive behavioral therapy. When it tended to be overactive as compared to the rest of the brain, they tended to do better with Lexapro. Now, the star is sort of mine that I've entered in here, just so you can sort of kind of apply this to people with anorexia. And anybody who does therapy with restricting anorexics will know this. We know that greater anterior insula activation happens when they're anticipating something happening in anorexia, and that also corresponds to alexithymia, that being that, especially restricting anorexics are not good at identifying their emotions. Therefore, they tend to be expressed in their body or expressed in avoidance or expressed in OCD or other symptoms. And if for those that aren't therapists, cognitive behavioral therapy, you have to have a cognition, you have to link it to a behavior, you have to figure out if there's distortions. And if you're not good at coming up with what that emotion is in the first place, your brain probably doesn't do CBT as well. And so you can maybe see how, if your brain works that way, it might not. So the hope would be, can we say which medicines work better based on a response? And as well, too, for those that are therapists, could we tell which types of therapies might work better depending on how your brain responds to some simple sense of stimuli or otherwise? So, the big picture here, is that eating disorders are mental illnesses. And I would actually emphasize that eating disorders most often and commonly are stress and anxiety disorders that are not always expressed in exactly the same way, which leads to, issues with how you approach them, how they respond to treatment. And the issue everybody finds that one size just cannot fit all, even within diagnosis like pure restricting anorexia, which tends to be probably a little more biologically pure than some others. Mental illnesses certainly have a loss of perspective, but there's these ideas that are important in that in mental illness, just like other medical illnesses, there's underlying traits. There's underlying ways in which the brain is pre-programmed, genetically programmed to put you at risk for eating disorders or not. Let's take something like restricting anorexia, pure restricting anorexia. You know, you're talking about less than 1% of people, maybe closer to 1% of females. And it is extraordinarily hard to get because the set of circumstances about how your brain works, how it responds to food, your ability to go without food, distort your body, all these kinds of things, your ability to not recognize the seriousness of it. Luckily, our brain has a lot of fail-safes to sort of, for most people, to get around this and not end up in the pit that is eating disorders. So you have to have a brain which is capable of getting eating disorder, and most brains are not. Now, just like all illnesses, those brains are acted upon, especially as they go through development, especially females, probably more than males, by hormones, by other developmental pressures about how the brain changes, especially frontal and limbic parts of the brain, which then, you know, and environmental pressures. So this is the idea of the environmental pressures of trauma, of stress, of just the pressure of getting older and doing things. And what's very specific about this is I think an underlying trait that almost all of our patients have is they don't have stress-resilient brains. They have anxious, less stress-resilient brains, which then obviously puts them at risk for anxiety and depression. It puts them at much higher risk going through the same trauma as somebody else of having post-traumatic stress disorder because their brains are just more sensitive. And so that risk is huge and carries through probably their recovery. Now, what I always say when people say, I don't want a not stress resilient brain, I don't want to be anxious, remember, it doesn't define everything about the patient. So we know that anxiety is correlated with high intelligence. Usually the smarter you are, ignorance really is bliss. The smarter you are, the more likely you are to have anxiety. It corresponds with empathy, your ability to connect to others, obviously if it's not so great to get in the way. So it's not a bad thing. And safety. So people that are, you know, really anxious, that reward systems don't work great, like in anorexia, they're less likely to use drugs or, you know, get pregnant early or, you know, jump out of an airplane without a parachute and not make it, or jump their bike off something. And if you're a younger kid. So again, it's all this balance that can make sense of why these traits survive in evolution. Now, what's different, I think, with our patients is illnesses are sustained by states. So, and I'll be as simple as possible. In anorexia, it is the state of malnutrition. It is the state of continual refusal and avoidance combined with lack of nutrition, which impacts the brain and how it works. Both internally, how everything responds and your body responds, as well as, unfortunately, how our environment responds to weight loss. And in bulimia, it still can be malnutrition. Oftentimes, they're not taking in good and adequate nutrition. If you're purging, you know, by emesis, you're obviously moving your whole GI system in reverse. You know, there's lots of things that happen, even in binge eating disorder, when you're overly reliant on carbs and get some other things that happen, can happen from weight gain. These all things I call sort of the quicksand that can sort of maintain the illness. So first of all, you really need to get nourishment back. You need to get somebody out of the cycle of binging and purging. And then long-term recovery really looks at, well, how does an individual, how'd you get here? What are your red flags? What are your, you know, what are your tripping marks that you have? And how do we live a life where you can avoid those in the future? So again, you got to have a brain with risk. And this comes down to genetics. I have 3 kids at home, 14, 11, and 7, and they are all wired very differently. And as a result of that wiring, they have different challenges at school, with friends, and I think everybody's that way. Knowing introversion and extroversion is obviously very popular nowadays, but you know, there are certain brains that have bigger or less risks, and it really takes a certain brain, certain reward systems, certain impulsivity to put you at higher risk for restricting anorexia, binge purge anorexia, bulimia, binge eating disorder, and then certainly if you're talking about younger kids or otherwise, you know, ARFID or restrictive food intake disorder, that these kinds of things come with, you know, certain traits and certain risks. And then you go through an environment, and again, if you go through an environment with a less stress-resilient brain, it's more likely to have an impact. And I think this intersection of trauma and eating disorders is not an accident. It has to do with the fragility and capacity of the underlying brain and how it interprets outside events. And so finally, certainly what's different in our field, what I call the quicksand is this state of the illness. It's malnutrition, it's binging and purging, it's cyclical phenomenon of revving your dopamine system up and then having it go down. These things sort of create a quagmire that you've got to get out of before you can address, okay, and also your brain doesn't work this way, now it's nourished. How do meds and therapy and other courses of action work to move you forward? So, when you can do and look at studies like this, one of the first things that you need to do is try to figure out, okay, if I have a brain, what kind of brains put me at risk for anorexia? Unfortunately, in the field, there's so little good science, really great science going on at this point, and not because there's not great scientists, just because of the volume of how long it takes to do a study, how many people are out there actually doing any sort of research, et cetera, that starting to get to the scope of things that other medical specialties have where they're looking at prevention and how we work things, they just take incredible numbers of people, an incredible amount of dollars. It's hard. But there have been some good studies where they basically will take patients that look as similar to possible as when they're adults. So the educational level and socioeconomic and background, skin color, all those kinds of things need to look as similar as possible. And the only thing different is that one has a history of having anorexia or bulimia and one does not. And then you look at, even before they ever went on their first diet or had their first binge purge episode, what were they like? What were these sort of underlying genetic traits that sort of defined them? And so in anorexia, in the few studies they've done, a big one, and I think this is a huge one, is negative emotionality and low self-esteem. So this is really the idea that they see the world as a dangerous, overwhelming place. They see themselves as not accurately to how the rest of the world sees them. They don't see themselves as friendly, pretty, capable. They don't see their body, obviously, the same way. That they tend to have lower self-esteems at baseline before they ever got sick, which I absolutely believe is genetically given. I think some people have a pretty accurate description of who they are. Some people, who I will remain nameless, maybe have much too great of a decision of who they are. And some people maybe have, a lower version of who they are. And that's probably, again, good in populations. For this population, that can cause problems, because trying to compliment them out of it, trying to convince them how smart they are, how they look, how capable they are, tends to only lead to frustration when these things don't change. They can sort of modulate over time, but usually it's something they've got to understand about how their brain works. I'm going to scrap some of these together to draw a picture that we're looking at in research and looking at possible risk factors. But this idea of perfectionism, anxiety, inhibition or avoidance, picky eating, and altered interoceptive awareness, which is a fancy word for how your stomach feels, breathing, just the internal sense of your body and how it works, which works through a part of the brain called the insula. One theory that we have, as a child psychiatrist, when a kid is less than 13, they don't have abstract reasoning, we see anxiety expressed with a lot of headaches and anxiety symptoms and avoidance, and a lot of times OCD symptoms as well that don't later become full-blown OCD. So one theory would be is like, let's take somebody with pure restricting ANR, anorexia, take a young lady in this case, so it certainly could be a young man, and she wants everything done very specifically. She's anxious, but maybe doesn't recognize herself as anxious. When she gets anxious, even before she went on her first diet, she would tend to go away. She would tend to withdraw. She would tend to avoid that which made her overwhelmed. She has a history of picky eating, which, as we know, if you treat anorexia, is not everybody, but it really signals this reward system that doesn't work. So for most of us, if you go without eating, as soon as you eat, you actually get more reward. Food is rewarding. It's one of the major rewards that we think of when you go on a date, when you go have an anniversary, when you're celebrating, you eat, eating feels good. And they tend to, A, avoid certain foods because maybe it makes their stomach hurt, and B, they also just don't get a lot of reward from food, which makes it sort of easier to avoid. The other thing is they tend to have altered interoceptive awareness. In other words, like how they interpret their stomach, how they interpret the internal way their body works seems to be off, which is very common in anxiety and depression. So these things sort of combine to this patient who experiences anxiety, probably experiences it in their stomach, doesn't recognize it. When they eat, they feel worse. When they eat, they don't get reward from it. And it sort of could develop in a pattern, an OCD sort of type pattern that, food avoidance makes them feel better. It's also the reason, next one, that they have obsessive compulsive personality traits. This really thing of their brain sort of feels out of order, but they don't know how to correct it. And so the more their meal plan, their outside world can have order, maybe the better they feel. And so I've talked about this in the picky eating part as well, but they have this real high level of reward dependence. They want to make straight A's. They want to be valedictorian. They want to go to that next stage of life and do things, but they don't have much reward reactivity. It really doesn't do it for them. And if you deal with individuals with restricting anorexia that are harm avoidant like this, they set themselves up. They go to Ivy League school. They do all these really hard things. They take on too much. It stresses them out. It makes it hard to eat. It makes them want to over-exercise or whatever else their eating disorder does to try to modulate their anxiety. And yet, even if they're successful, it doesn't actually sort of ring their bell, so to speak. It doesn't make them feel better. And so when I'm talking to my patients, picking out these things and realizing how their brain works actually can get them to come up with plans that make sense for their brain, right? If I know my spirituality or my connection with people or something else is actually going to provide me with more meaning and not stress me out, maybe that's better to focus on rather than being valedictorian, which the day I get it, I just somehow minimize it anyway. As well as it looks the fact that because their reward systems don't work, when you're doing behavioral training with these patients, people get really frustrated because stars and rewards and phones and cars don't work because their reward systems don't work. Now, their punishment systems are overly sensitive, right? So if you ever are going to give them a negative comment or whatever, they'll do everything they can to avoid that. And if you ask most anorexics why they get straight A's for school, and you give them the two choices of because it makes me feel good to get an A versus I'm scared to death to get a B because it'll mean I'm an idiot, most all of them are going to choose I'm scared to death of getting a B or a bad grade. It just reinforces their low self-esteem. And so understanding their brain works that way will help them not only negotiate how they do with eating, but life and relationships and everything else as well. When you do this same sort of studies with bulimics, and interestingly enough, let's take the big picture of bulimics, which is they still feel anxious. They still try to diet because they're thinking that if they lose weight usually, or if they look a different way, they'll feel better about themselves. But they're not wired the same way, so it's hard just to avoid food. They do get a lot of reward, and so they'll get some carbohydrate cravings when they don't eat. They get reward both from binging as well as reward from the undoing of purging or whatever else they do. And so these things, they're similar in that they're also tend to be pessimistic or negative emotionality. They tend to have low self-esteem, which again doesn't accurately reflect who they are. They tend to be anxious and fearful, which for a patient who's sometimes experimenting with drugs and sex and other impulsive dopaminergic activities, you don't always think of anxiety and fearfulness when you think of that. I think we're we sort of have a implicit bias that anxiety, the mouse scurrying and going in the corner is how we view it. But anxious fearfulness is really just about stress. It can be expressed as anger. It can be expressed as frustration tolerance. It can be expressed as drinking or doing other things just to make yourself feel better as soon as possible. So when they get anxious and fearful, they tend to want to do whatever is necessary because, again, their reward system is very reward sensitive and not as punishment sensitive, right? So they're not as worried about if they shoplift getting caught, or it's that dopamine thing that makes their brain feel better. It just tends to get them in more trouble, and this leads to the cycle of things. When they don't eat, they do get hungry, and then they get even more reward from the carbs that they eat when they binge, and sets up this cycle. And we've seen lots of neural models of this, whether it comes to, there's a neural model of this in binge eating. There's a neural model of this in drug and alcohol abuse, where it's the cycle of dopaminergic, chasing after the dopamine, the feel good, to try to make the anxiety go away. Tend to have more obsessive compulsive personality traits as well. Lots of mood lability. So this up and down, this back and forth tends to create the roller coaster that is mood lability or affect dysregulation as well. The problem is, especially as a psychiatrist, is that mood lability and affect dysregulation does not equal bipolar disorder. Bipolar disorder really requires mania and sleep changes, genetic and biologic changes that you see throughout generations. And the problem is, when they see this, they'll put them on quote unquote mood stabilizers, which nowadays, the Zyprexas and Risperidals and Seroquels of the world, these medicines hit so many neurotransmitters. They're sort of like a smart bomb that hits everything. They're actually great anti-anxiety and antidepressant agents as well as augmentation or by themselves. And so you put them on this mood stabilizer, you stop them from binging and purging, and they look better, and you say, see, I cured their bipolar disorder, when really all you've done is, A, you're working and treating their anxiety, you're getting them out of the symptoms, which create the chaos and the up and down for them, and they probably might and don't have bipolar disorder. You've just really treated their anxiety and got their symptoms to get under control from another way. But again, more impulsive, more trying to get well as soon as possible. And these are extremes, right? So not everybody's brain's the same. So you might take different components of this and see how they work for individual patients. So if you're going to have this, then it has to be genetics. And I won't bore you with all the genetic stuff, but again, only in the last 20 years probably has the idea that anorexia is a biologically controlled genetic mental illness is a new one. For so long, it was control, environment, parents, everything else that was causing these issues. And so the fact that more than half of this disorder is contributed genetically to the traits that the brain is born with in the first place. There are cross-transmitted between anorexia and bulimia, probably because some of those subsets are cross-transmitted. You tend to see sub-threshold things in family members, whether it's set shifting or ideas about exercise or weight or body. And there's going to be no giant anorexia or bulimia genes, so we're always looking for smaller parts of the disorder, which might control smaller brain circuits. So set shifting, low self-esteem, egosyntonic vomiting. These are kinds of things that you might find a stronger genetic link, because there's not going to be just one genetic hit that's going to be, hit for all of anorexia. So, and like anything, genetics does load the gun. You still need something to pull the trigger, and for some people it's a hair trigger and you can do everything right and have no trauma and develop an eating disorder. For some people, you got to stomp on it pretty hard. Their brains can be resistant, but maybe they just go through enough where the idea of using eating disorder symptoms somehow makes their anxiety better. All right, so, and as you look at this, here's a good model when I talk about brain and stress resiliency. So this was actually done at a Science magazine, and this is a depression study. It looks at serotonin. Serotonin's another big hormone for appetite and satiety that we'll talk about. But when you look at this, basically there was a long version, the double L, made your brain a little more stress resilient. The double short S made your brain a little more stress sensitive. And so you can see as they go through stressful life events, if you have a resistant brain, your chance of depression goes up to about 17%. If you follow the regular blue line up and you have a more stress sensitive brain, it goes up to almost 40%. So take this to look at risk for anorexia, as well as maybe risks of self-esteem or amount of exercise use, or how the brain responds to lack of calories, that there's going to be these risk factors, and you can sort of know that some people will be at higher or lower risk just depending on the sensitivity of their brain to different factors. So you get the trait part, and then the question is, then what do they go through to get them there? So first of all, Kelly Klump out of Michigan State does some great research on estrogen. There's some really great research being done on testosterone now and estrogen for male eating disorder patients. Certainly I think we have more data. I certainly think there's some issues with testosterone, but for, most of my practice under the age of 12 as a child psychiatrist, not eating disorders, is boys, and most of my practice over the age of 12 is girls. There's something about estrogen. It changes serotonin, changes cortisol, which is a stress hormone. It changes these frontal or planning circuits and these limbic or emotional circuits. That's a big deal. And that certainly leads to different risks of things. Things get complex, body weight changes, prime time of anxiety, probably because of changes that I described above, that there's these things that happen Puberty is especially a big risk for a lot of my female patients, especially. Probably less of a risk for male patients, but for male patients, you see this started menarche, started changes, symptoms around their period, these kinds of things that can be important that you need to track. And then when we talk about environment, again, it's a hard environment. You know, if you read the studies on the likelihood of being inappropriately touched, certainly things from the Me Too movement have brought up just how commonplace these things are. And if they're very common and you have any type of brain, it's hard. If you have a stress-sensitive brain, it makes it extra hard. You start to realize the world's a big place, your family things happen. We live in a high-stress environment that expects a lot out of kids, too young from an early age, both intellectually, sport-wise, sexually. We just do not do kids a favor. And we live in a fat-phobic culture, right? So when our patients, should they have an eating disorder where they lose weight, certainly not all of them do that, but if they do, they get a lot of compliments and feedback when they could actually be starting something that could kill them. So then there's the questions of the quicksand, right? And there's a question of when they start these things, why don't they stop? For anorexia, it's about nutrition, nutrition, nutrition. So if you look back at the Keyes experiment after World War II, they were trying to actually not to refeed people coming out of concentration camps, and they were using male conscientious objectors to see when we starve them out and refeed them, how do we refeed them without giving them refeeding syndrome and killing them? But what they saw was just by getting them not nourished without any of those other traits that we talked about, because these people weren't at high risk for eating disorders, that they did get depressed and have stomach aches and headaches, preoccupied with food, withdrawn, they didn't think right. All those things on top of all those other traits makes it very hard to get to a malnourished brain and make it work. We also know that malnourished brains don't respond to therapy as well. They don't respond to medicines as well. And so the importance of proper nourishment can't be under recognized. What's the other thing that happened though? If estrogen makes your brain a little overwhelmed or other kinds of things, especially for females, they regress, you know, the period drops, estrogen has to be converted by peripheral body fat. So they actually simplify out their hormones and make their brains a little less, you know, scrambled as a result of it. They also, we know that people with anorexia tend to have this excess limbic serotonin, probably responsible for error detection, anxiety, brain sensitivity. And when you don't eat, you don't take in tryptophan, you actually lower serotonin levels and probably numb their brains out a little bit and make them feel better. Unfortunately, this is also a finding that we see in people that commit suicide. And don't forget, especially in eating disorders, highest rate of suicide of any mental illness, even higher than depression and bipolar disorder in a lot of studies. So what happens, unfortunately, is there's a hormone called CRH, or cortisol releasing hormone. And what happens is it's supposed to be for populations that when you're not eating, you're supposed to get pissed off and go chase down some buffalo and then bring it back for the tribe to eat. But in our patients, it causes them to be irritable. It causes them to move more, which is hard when you're trying to weight restore them or trying to get them back to normal. And they don't want to eat, which is certainly what they need to do to get their brain nourished again. So there starts to develop these cycles that you can see with, you know, some of these things actually leading their brain to feel better. And these are probably somewhat subconscious or unconscious, but leads to a cycle of worsening mood. We obviously know as they lose weight, there might be some relief, but they long-term, their brains don't work better, they don't feel better, they don't combat depression or do well socially. And if we do our job and weight restore them, it just makes them feel bad. And that's the hardest thing in medicine. Anytime you make somebody feel worse, it makes the job of getting them well very hard to do. I have a lot of compassion. My inpatient practice is a lot easier than my outpatient practice because I know where they are and what they're doing and what they're eating and how their bowels are working. I know everything. Outpatient, I have to sort of trust things. I have to not push things so far that they don't come back and I can't treat them. It's a careful balance when you're doing something to a brain that's going to help it in the long run that makes it feel worse in the short run. So in bulimia, I'll be more simple. So again, theirs is more dopamine driven, this reward chemical. And it's the reason why you can't just play whack-a-mole with the eating, that you got to watch for drug and alcohol, for sexual addiction, for you know, shoplifting, you know, other kinds of things, gambling. There's lots of things that come up that they just want to feel better as soon as possible. And robbing Peter to pay Paul or doing one to get the other is not necessarily a good place to be. But we see that in studies that there's these oversensitive dopamine reward systems, which make them feel better. And so I'll talk to a lot of my patients in sort of an addiction sort of model, which is, are you sober? Are you finding other ways to take care of your anxiety that's not going to make things worse for you in the long run? Are you eating a regular meal plan so you don't get hungry and extra reward from food from binging? Are you taking care of yourself in a way where you take care of your anxiety without making your self-esteem even worse, without ruining your relationships? Those kinds of things becomes really important to understand that their brains are very sensitive to rewards, to try to use that in positive ways. There's definitely positive ways that can do that, and that maybe their negative reinforcement stuff isn't as powerful, and understanding that reward system can make a difference in behavioral planning as well. So again, got to have a brain, got to go through some environmental factors, hormones, puberty, stress, especially if your brain's more stress sensitive, and then we talked about state factors. So in my little bit of time left here, this is actually a study that we did from the Laureate Institute for Brain Research. I'm not sure if you can see my cursor here, but that place that's circled is sort of the middle of the brain. The insula, this is the brain cut in half, and the insula sort of runs back from here. So this is dorsal mid-insula. And what we know in depression is that whether you ask them to think about their heart rate, to think about their stomach, to think about their bladder, it's different. Their insula just doesn't work, and it puts them at higher risk. What we saw different in people that struggle with anorexia is it seems to be that there's a lot higher sensitivity to their stomach and their feedback from their stomach than there was anything else. Now you can see it approaches, a P of 0.05 in bladder. And remember, anorexics actually do have a slightly higher rate of enuresis. And when we asked them, the same patients and same controls, to actually think about, not food, because we don't want to get the food and stomach stuff mixed up, but we asked them to think about home and friends, or home, family, friends, and academics and stressors, the same area of the brain sort of lit up. And so I think there is this sort of cross, like their anxiety is being misinterpreted through their stomach about fullness and avoidance, and that it causes more of a problem or is an underlying problem that makes it harder for them to eat. And so what we see with visceral interoception, which is their stomach, is a group of patients who they could not pay attention to hunger and stomach stuff, and they overcome that. They have lots of preoccupation with their gut and stomach. They tend to be stomach anxious people at higher rates than those that aren't, and have a hard time describing their stress, so they tend to experience it somatically. They have certainly a heightened level, that stress-sensitive brain, of fear and anxious rumination and obsessive-compulsive type symptoms. And then, enduring anxiety-related personality traits, avoidance, comorbid stuff, traits that are there for long-term. And in the middle is sort of this visceral interoception that's related to the stomach. Why do you get butterflies when you're excited? Why do you throw up before you have a big test? I mean, these kinds of things and these connections are very important for our patients. Now, do I think the insula is the end-all, be-all for anorexia? No, but I think it's the first truck stop between our body and our brain. And if we can understand about how this circuit works or doesn't work, how it works when they're not weight restored and they're weight restored, and we connect it to the other areas of the brain, we can start to roadmap out how do these connections work, how do they result in symptoms around eating, anxiety, body image, etc., that hopefully will lead to better outcomes. So these are my kids. This is us enjoying down, if anybody's from Florida, down in St. Petersburg at the Candy Kitchen. But I'm happy to take, I think I finished with some time. I got 4 minutes left. So happy to certainly take any questions if there is any.
Thank you so much, Dr. Moseman. We don't have any questions right at the moment, but we have had a couple of requests from the last session about how they can get in touch with our presenters. How can people get in touch with you if they do have questions later on? Or for some of our registrants, they'll be watching this video later. If they want to get in touch with you, how should they go about doing that?
Absolutely. And I can certainly email this to you, Kirsten, as well. But my email is semoseman, SEMOSEMAN, at saintfrancis.com. That's SAINTFRANCIS.com. You can email me, and they're not proprietary or anything. I just ask if you ever use them, you give me some credit, or if, and happy to have you use them to, to educate others or use for your own personal use.
Perfect. So I'm going to put Dr. Moseman's email address in the chat. And I just want to confirm it's SEMOSEMAN@stfrancis.com. Is that correct?
That's correct. Yep, absolutely.
Perfect. All right, so there is his email address, and we are all set. Thank you so much, Dr. Moseman. That was absolutely fascinating. Thank you so much.
Great, you're quite welcome.
Of course, and I just want to let all of you know, if you sat in on that incredible presentation and you are interested in getting a CE continuing education credit for that, I am going to send you a link to a Google survey right now. I'm also putting that in the chat feature for this conference. There you go. It is a link to a Google survey. If you can fill that out, complete it, submit it, and send it to us, that will enable us to get you that CE credit. So we're going to say goodbye to Dr. Moseman. Thank you so much for your time. We really appreciate it, and I hope you have a wonderful day.
Great. Thank you so much for having me.
All right. Thank you.